Artificial Intelligence Dr. www.abcpharma.net/English. User question. What is the role of PSA kinetics, such as PSA velocity and PSA doubling time, in differentiating between benign prostatic hyperplasia, BPH, prostatitis, and prostate cancer in patients with PSA levels in the 4.0 to 10.0 nanograms per milliliter range? Claude AI answer. This is an excellent question that delves into the nuanced use of PSA kinetics in the challenging, diagnostic gray zone of PSA levels. PSA kinetics, particularly PSA velocity and PSA doubling time, can provide valuable additional information to help differentiate between benign conditions and prostate cancer. Let's break this down. PSA velocity, PSAV. Definition: the rate of change in PSA levels over time, typically measured in nanogram per milliliter per year. Role in differentiation: 1. Prostate cancer. PSAV greater than 0.75 nanograms per milliliter per year is associated with increased risk of prostate cancer. Some studies suggest a threshold of greater than 0.35 nanograms per milliliter per year for younger men. 2. BPH typically shows slower PSA increases, often less than 0.75 nanograms per milliliter per year. However, there can be significant overlap with cancer. 3. Prostatitis may cause rapid, transient increases in PSA that quickly return to baseline. Considerations: requires at least 3 PSA measurements over 18-24 months for accurate calculation. More useful in men with lower PSA levels, less than 4 nanograms per milliliter, for early detection. Less specific in the 4-10 nanograms per milliliter range due to overlapping velocities between cancer and BPH. PSA doubling time, PSADT. Definition: the time it takes for the PSA level to double. Role in differentiation: 1. Prostate cancer. PSADT less than 3 years is associated with increased risk of prostate cancer. Shorter PSADT, e.g., less than 1 year, may indicate more aggressive disease. 2. BPH typically has longer PSADT, often greater than 3 years. 3. Prostatitis may cause rapid doubling but usually returns to baseline quickly. Considerations: more commonly used in monitoring known prostate cancer rather than initial diagnosis. Can be calculated with fewer measurements than PSAV. May be more useful in men with higher baseline PSA levels. Comparative effectiveness: 1. PSAV versus PSADT. Some studies suggest PSADT may be more specific than PSAV in predicting prostate cancer. PSAV is more commonly used in initial diagnosis scenarios. 2. Combination with other factors: PSA density, PSAD, PSA level divided by prostate volume. Free PSA percentage, lower free PSA percent associated with higher cancer risk. Challenges in the 4-10 nanograms per milliliter range. 1. Overlap. Significant overlap in PSA kinetics between BPH and low-grade prostate cancer in this range. 2. Variability. PSA levels can fluctuate due to various factors, e.g., ejaculation, prostate manipulation. 3. Timeframe. Requires multiple measurements over time, which may delay diagnosis. 4. Inconsistent cutoffs. Lack of universally accepted thresholds for PSAV and PSADT in this specific range. Approach to using PSA kinetics in the 4-10 nanograms per milliliter range. 1. Serial measurements. Obtain multiple PSA measurements over time to calculate PSAV and PSADT. 2. Consider age. Use age-adjusted PSA velocity cutoffs. 3. Integrate with other factors. Combine with digital rectal exam findings, family history, and other risk factors. 4. Use risk calculators. Incorporate PSA kinetics into comprehensive risk assessment tools. 5. Additional biomarkers. Consider using Phi-4 Ks-score or PCA3 tests for further risk stratification. 6. Imaging. Multiparametric MRI can be valuable in this PSA range, especially with concerning PSA kinetics. 7. Shared decision-making. Discuss the implications of PSA kinetics with patients, considering their preferences and risk tolerance. Future directions. 1. Artificial intelligence. Developing AI algorithms to interpret complex PSA kinetics patterns. 2. Personalized thresholds. Establishing individualized PSAV and PSA-DT thresholds based on genetic and demographic factors. 3. Integration with molecular markers. Combining PSA kinetics with emerging molecular markers for improved accuracy. 4. Prospective studies. Conducting large-scale, prospective studies to better define the role of PSA kinetics in the 410 nanograms per milliliter range. In conclusion, while PSA kinetics can provide valuable information in differentiating between benign conditions and prostate cancer in the 410 nanograms per milliliter range, they should not be used in isolation. Their interpretation requires careful consideration of multiple factors and should be part of a comprehensive risk assessment. The greatest utility of PSA kinetics in this range may be in identifying men who need more urgent evaluation or additional testing, rather than as a definitive diagnostic tool. As our understanding of prostate cancer biology and biomarkers continues to evolve, the role of PSA kinetics will likely be refined and potentially enhanced by integration with other novel diagnostic approaches.